All right, so you're all set, and I'm going to turn it over to you, and you can start whenever you're ready, okay?
All right, awesome. I'm going to wait one more minute just to see if anyone is taking a while to log into Zoom, and then I'll get started. All right, I'm going to get started. And so if you're having, I'm not very technologically advanced, so if you can't hear me or there's an issue, just flag me, raise your hand, or interrupt and let me know. I'm welcome to my ACVNU Journal Club. I'm Rachel Cooper. I'm in my first year of my ACVNU residency, and I'm doing a remote residency with UC Davis and Mass Vet Referral Hospital outside Boston. And my article, Estimates of Urine Calcium Excretion in Dogs with and Without Calcium Oxalate Urolithiasis, was recently published in the September-October edition of JVIM by the group at University of Minnesota, listed at the bottom of the slide. And so I thought I'd start with just a quick background on calcium oxalate urolithiasis in dogs. As we know, it's a very common problem. Calcium oxalate stones were reported in 48% of urolith submissions from the United States to Minnesota Urolith Center in one study from 2019. They're also very recurrent. So in another study, 50% of dogs with calcium oxalate stones had a recurrence of their stones within 2 to 3 years. Several studies have shown that idiopathic hypercalciuria, defined as increased urine calcium excretion with a normal blood or serum calcium concentration, is a risk factor for calcium oxalate urolith in dogs. A 24-hour urine collection is the gold standard for evaluation of urine calcium in humans. However, this is logistically difficult in dogs due to a variety of reasons. In humans with calcium oxalate stones, urine calcium creatinine ratios in fasting urine samples is highly correlated to the 24-hour urine calcium excretion. We don't know how the spot urine calcium creatinine ratio correlates to a 24-hour urine calcium excretion in dogs. Another option is measuring fractional excretion of calcium, which is the amount of filtered calcium that escapes renal tubular absorption and is excreted in the urine. In humans, fractional excretion of calcium is increased in adult patients with calcium urolithiasis compared to healthy individuals. Data with fractional excretion of calcium in dogs with calcium oxalate uroliths is lacking, but the authors wondered if it could be an alternative or even superior to the urine calcium creatinine ratio for predicting the presence of hypercalciuria. So for the primary objectives of the study, the authors wanted to determine the performance of fractional excretion of calcium and urine calcium creatinine ratio in dogs for differentiating between idiopathic calcium oxalate stone formers and non-stone formers. Their hypothesis was that dogs with calcium oxalate uroliths would have higher fractional excretion of calcium and urine calcium creatinine ratios than the control population without stones. Their secondary aims was to identify thresholds for both fractional excretion of calcium and urine calcium to creatinine ratios in dogs that will optimize discrimination of calcium oxalate stone formers from non-stone formers. Their hypothesis was that neither fractional excretion of calcium or urine calcium creatinine ratio thresholds will achieve both a high sensitivity and specificity for discrimination between calcium oxalate stone formers and non-stone formers. So before we get too far into this study, I just wanted to touch on some of the historical studies of urine calcium creatinine ratio. And so this one is a study that was published in 2015, looking at fasting urine calcium to creatinine ratios and oxalate to creatinine ratios in different breeds of dogs with stones versus breed matched controls. Miniature Schnauzers, Bichon Frise, and Shih Tzus all had significantly higher urine calcium creatinine ratios in the stone forming group compared to controls. They also found that being on a therapeutic diet was associated with a higher urine calcium creatinine ratio. Urine oxalate to creatinine ratio was not significantly correlated to stone status in any breed, and that blood ionized calcium levels were higher in the cases versus controls in both the miniature Schnauzer and Bichon groups, but not the Shih Tzu group. It was very hard to find studies that looked exclusively at fractional excretion of calcium. And there were not any that I could find looking at fractional excretion of calcium in the past 20 years associated with the urolith formation. But I did find this study that looked at fractional excretion of calcium and other electrolytes in dogs with AKI. And this prospective study compared the fractional excretion of electrolytes in dogs with either volume responsive or intrinsic causes of AKI and compared these to controls. The authors did find significantly different fractional excretion of calcium and other electrolytes between the two different causes of AKI and control groups, and also found that the fractional excretion of calcium and other electrolytes were significantly higher in non-survivors compared to survivors. Finally, this next study was a retrospective study from the Veterinary Journal, which looked at newly diagnosed dogs with pituitary-dependent hyperadrenocorticism and compared them to clinically normal dogs labeled as C and D and sick control dogs labeled as SCD in this box chart below. They found that the urinary fractional excretion of calcium in PDH dogs was significantly higher compared to controlled normal dogs and the sick control dogs. And then the box, you can see the box plots of the urinary fractional excretion of calcium in these dogs with pituitary dependent hypercortisolism, the normal dogs, and the sick control dogs to the left. So back to the original study that I'm presenting today. This study was set up as a retrospective cross-sectional design from a database of 202 dogs that had participated in previous and ongoing calcium oxalate urolithiasis studies at the University of Minnesota. The cases had been obtained between February 2011 and March 2023. Stone formers were defined as dogs who had had previously at least one episode of calcium oxalate urolithiasis where the stone contained a core of at least 70% of calcium oxalate determined by standard polarizing light microscopy and infrared spectroscopy methods by the University of Minnesota Urolith Center. The control dogs had no history of uroliths and confirmed absence of uroliths on abdominal radiographs, ultrasound, or both. Inclusion criteria were dogs that were greater than or equal to 2 years old. They had to be normal calcemic based on ionized calcium levels and non-azotemic. The blood samples and urine samples had to be obtained after at least a 12-hour fast, and they needed to have concurrent urine calcium, urine creatinine, blood ionized calcium, and blood creatinine. Exclusion criteria included hypercalcemia, defined as an ionized calcium of greater than 5 milligrams per deciliter, which is 1.47 millimoles per liter for people who are more familiar with those measurements. Azotemia, defined by creatinine of greater than 1.4 milligrams per deciliter, or a BUN greater than 31 milligrams per deciliter. Dogs who received systemic glucocorticoids in the past month or topical glucocorticoids in the past 7 days. Other dogs with known effects on urine calcium excretion, including furosemide, hydrochlorothiazide, or levothyroxine. Dogs under anesthesia at the time of sample acquisition due to the effects of sodium-containing IV fluid therapies on increasing urine calcium excretion in dogs. Or confirmed other diseases that alter urinary excretion of calcium, including diabetes and hyperadrenocorticism. Urine was collected either by midstream free catch or cystocentesis and run on the reference lab analyzer. In August 2018, they changed the urine creatinine calibrator reagent, which ended up with a decrease of urine creatinine concentration by 13% as measured by internal validation. And I'm mentioning this because they do additional analysis on this, which we'll talk about later looking at these implications. For blood, the ionized calcium and creatinine levels were determined by ISTAT. Urine calcium creatinine ratio and fractional excretion of calcium were calculated for each dog. The urine calcium creatinine ratio is defined as the urine calcium divided by urine creatinine. The measurements cancel out, so there's no there's no measurement associated with this. It's just a number. And then fractional excretion of calcium was calculated as the product of urine calcium times the plasma creatinine divided by the product of plasma calcium and urine creatinine. The measurement for this is expressed in milligrams per milligram. For statistics, continuous data were tested for normality with a Shapiro-Wilks test. And data that had normal distribution, which just ended up being ionized calcium concentrations, were reported as mean plus or minus standard deviation and compared between calcium oxalate stone formers and controls with a t-test. Data that did not have normal distribution, which ended up being the BUN, fractional excretion of calcium, urine calcium creatinine ratio, age, and weight, were reported as medians with a range, and then compared between calcium oxalate stone formers and controls with Wilcoxon's rank sum test. For fractional excretion of calcium and urine calcium creatinine ratios, thresholds were selected in 0.1% and 0.01 milligram per milligram increments, and sensitivity and specificity were determined for each threshold. ROC curves were used to determine the optimal thresholds for fractional excretion of calcium and urine calcium creatinine ratios. Bierman rank correlations were used to evaluate the strength and direction of the relationship between fractional excretion of calcium and urine calcium creatinine ratio. Multivariable regression models were built to test predictors of fractional excretion of calcium and urine calcium creatinine ratio, including evaluation for urolith status, sex, age, breed, ionized calcium, and creatinine agent, old versus new. For breed, they compared miniature Schnauzer versus other breeds of dogs because the non-miniature Schnauzer dogs comprised of less than 5 dogs in one or both of the calcium oxalate stone status groups. Models were also created for just the subset of calcium oxalate stone formers to test predictors that varied only in that group, including therapeutic diets versus other diets and recurrent stones versus not. And they used a p-value of less than 0.05 for statistical significance. So here are the results. And data from 157 dogs were reviewed for eligibility. 36 dogs were excluded. 18 of those were under anesthesia at the time of sample acquisition. 9 were eliminated for azotemia, 4 for hypercalcemia, 3 for medications, 1 for diabetes mellitus, and 1 for hypercortisolism. After exclusion, there were 121 dogs in the final study group. 68 of these dogs had been previously published in other studies, and 42 of these dogs were calcium oxalate stone formers, and 79 were control dogs. I used yellow to highlight their initial population statistics, which found that there was a greater proportion of male dogs in the calcium oxalate stone former group compared to the control group. No significant differences were found between age and body weight. These results were specifically looking at the stone formers in this study. So 23 out of 42, or 55% of dogs, were recurrent stone formers. In addition to the cystoliths, 38% of dogs also reported nephroliths and 12% had ureteroliths. Interestingly, they report that the ureterolith dogs were all male. The sex distribution for the nephroliths was not reported. The breeds represented comprise mostly of dogs that we anticipate as being high risk for calcium oxalate stones, including 20 miniature Schnauzers, 5 Yorkies, 4 Bijans, and 2 Shih Tzus, but also 6 mixed breed dogs and a single Staffy, Australian Shepherd, Chihuahua, Fox Terrier, and a Kerry Blue Terrier included. The 16 case dogs and 4 control dogs were fed therapeutic urinary diets, including 2 dogs that were eating a renal diet. The remainder of the dogs ate either over-the-counter or home-cooked diets. The 4 control dogs that were fed a therapeutic urinary diet were fed that due to housemates having historical urinary stones. So now we're going to go back to that first table and now look at the results from blood and urine measurements between the 2 groups. Statistically significant differences between blood creatinine and BUN concentrations were not detected between the 2 groups. But blood ionized calcium, fractional excretion of calcium, urine calcium creatinine ratio, and urine calcium were greater in the stone former group than in the controls. And because I'm not used to looking at ionized calcium in milligrams per deciliter, I'm going to report also the mean ionized calcium of the calcium oxalate stone formers at 5.5 is 1.37 millimoles per liter with a standard deviation of 0.07. And the control group mean ionized calcium is 1.27 millimoles per liter with a standard deviation of plus or minus 0.05. Here is the data and table describing the receiver operating curve for fractional excretion of calcium. The area under the curve was 0.68, and the red dashed lines indicate the threshold that maximizes the sensitivity and specificity, which ended up being a fractional excretion of calcium of 0.56%. So using the fractional excretion of calcium of 0.56 showed a sensitivity of 74% and a specificity of 58%. You can look at this table as well that shows that as you increase your fractional excretion of calcium threshold, your sensitivity is going to decrease and your specificity is going to increase. And here's a similar data and table describing the ROC curve for urine calcium creatinine ratios. The area under the curve was 0.69, and this red dash line indicates that the threshold that maximizes the sensitivity and specificity was, and the point was 0.056 milligrams per milligram. So using the urine calcium creatinine ratio of 0.056 milligrams per milligram, we showed a sensitivity of 60% and a specificity of 75%. You can also look at this table and look for the same thing, that as you're increasing your urine calcium creatinine ratio threshold, your sensitivity is going to decrease and your specificity is going to increase. They also did find a strong correlation between the fractional excretion of calcium and the urine calcium creatinine ratio, with a Spearman rank of 0.94 and p-value of less than 0.001. Looking at multivariable regressions, these analyses were performed to evaluate calcium oxalate urolith status, age, sex, urine creatinine reagent method, ionized calcium, and breed, which was again Schnauzer versus other, as predictors of fractional excretion of calcium and urine calcium creatinine ratio. Being a calcium oxalate stone former was predictive of a greater fractional excretion of calcium and urine calcium creatinine ratio, with a p-value of less than 0.001. And male sex was interestingly a predictor of lower fractional excretion of calcium and urine calcium creatinine ratio. And these are box and whisker plots of fractional excretion of calcium on the top and urine calcium creatinine ratio on the bottom, comparisons of control dogs, which are the open circles, and calcium oxalate stone formers, which are the closed circles separated by sex. The red dashed lines indicate the thresholds for both variables that maximize sensitivity and specificity. But you can also appreciate how the male dogs tended to have a lower fractional excretion of calcium and urine calcium creatinine ratio compared to the female dogs. And the stone formers had a higher fractional excretion of calcium and urine calcium creatinine ratio compared to the non-stone formers. Within the stone former group, they did not find any differences between whether they were fed therapeutic diets or not, or the dogs who had recurrent calcium oxalate uroliths versus dogs that were first-time offenders. All right, now moving on to the discussion. Both fractional excretion of calcium and urine calcium creatinine ratio were significantly higher in the stone formers than the control groups, confirming that hypercalciuria is a key risk factor in calcium oxalate stone formation in dogs. However, as predicted by the initial hypothesis of the authors, diagnostic performance of fractional excretion of calcium and urine calcium creatinine ratio only had moderate sensitivity, so 74 and 60% respectively, and specificity, 58 and 75% respectively. So it's not a perfect test for screening alone. Urine calcium creatinine ratio and fractional excretion of calcium did have very strong agreement, so measuring both is probably unnecessary, and the authors suggested that since urine calcium creatinine ratio does not require serum, it's cheaper and easier to do. These findings are also similar to those found in the previous evaluation of urine calcium creatinine ratios in dogs with stones, and they actually found a similar threshold but had a higher specificity. The authors noted that the confidence intervals overlap between this study and the previous study, so the difference in the specificity could be due to random sample variability. It could also be due to the variability in the study design. The previous study only included a small number of male miniature schnauzers, while this study included both sexes and multiple breeds. Control dogs in this study could either have had radiographs or ultrasound to be included, but the control dogs in the previous study required ultrasound. So the authors posited that the radiographs may have missed some stones and erroneously classified some dogs as controls. In the multivariable analyses, male sex was found to predict lower urine calcium creatinine ratio and fractional excretion of calcium. Despite that, they were overrepresented in the stone forming groups. So stones may be forming in these dogs at lower levels of calciuria. The authors suggest that this may be due to anatomic or functional differences in the lower urinary tract, but it could also be that females could be protected from forming stones at the same degree of hypercalciuria as male dogs from higher citrate excretion or lower oxalate excretion in females. The authors commented that the substantial overlap in fractional excretion of calcium and urine calcium creatinine ratio between cases and controls may represent true biologic overlap or may be related to using spot samples. So they question if it is possible pooling samples may decrease the variability. In studies of humans, they found that humans have had little intra-individual variability in 24-hour calcium measurements, so a single measurement would be adequate for them. In healthy dogs, a study has found a relatively higher intra-individual variability of urine calcium creatinine ratio and fractional excretion of calcium, which could have contributed to the variability seen in this study. In this study, the authors chose to use ionized calcium because protein-bound calcium fraction is not excreted in urine. Ionized calcium has been found to be highly correlated to the filterable fraction of calcium. Although all study participants were normal calcemic, mean blood ionized calcium levels were slightly higher by 0.1 milligram per deciliter in calcium oxalate stone formers than in controls. The author suggests that the origin of the idiopathic hypercalciuria could be intestinal or absorptive, bone or resorptive, or both. The author then quotes a study that showed that dogs with calcium oxalate urolith have lower serum beta cross-lapse concentrations, and that's a marker of bone turnover, and a subset have reduced deactivation of calcitriol, so they suggest that the absorptive hypercalciuria is more likely. Some limitations of this study that the authors brought up included that some of the dogs with confirmed calcium oxalate uroliths had been started on therapeutic urinary diets and potassium citrate prior to sample collection. Therapeutic diets are formulated to reduce urine calcium concentrations, and potassium citrate also reduces urinary calcium excretion by about 30% in humans. Inclusion of stone-forming dogs receiving a diet or supplement with potassium citrate could have underestimated their fractional excretion of calcium or urine calcium creatinine ratio. And so they questioned, should these cases have been excluded like they excluded other medications that alter calciuria? Another limitation is that the control group population was made up of similar breeds that are predisposed to stone formation. Breeds that are high risk for calcium oxalate uroliths may be more likely to be hypercalciuric, so it's possible that these results are not representative of all breeds. Finally, other limitations include the retrospective design and the use of spot samples instead of a 24-hour urine collection. And so the conclusions of this study are that fractional excretion of calcium and urine calcium creatinine ratio moderately differentiate calcium oxalate stone formers from controls. There's a strong correlation between fractional excretion of calcium and urine calcium creatinine ratio, so only a single test, which they state urine calcium creatinine ratio, is sufficient. And a urine calcium creatinine ratio of greater than 0.056 milligrams per milligram identify hypercalciuria in about 60% of calcium oxalate dogs. These results support using urine calcium creatinine ratios as a pragmatic monitoring tool for calcium oxalate prevention programs. So when reading these articles, I always like to think about what the clinical implications are and how these should direct my day-to-day practice. And I'm curious to know how many people are measuring urine calcium creatinine ratios on dogs and using them to either decide whether to start on hydrochlorothiazide or potassium citrate, and then are people retesting to make sure they improve to reach normal urine calcium levels? And should the goal be less than 0.056 milligrams per milligram, or should we relook at those ROC charts to look at either a more sensitive or lower value to include more animals? Could sex-specific thresholds improve predictive values? It seems that males overall had lower urine calcium creatinine ratios and fractional excretion of calcium, but they're overrepresented as calcium oxalate stone formers. If we calculate sex-specific values, would they be more sensitive and specific for prediction of stone formation compared to the more generic ones they gave us now? And certainly, as a thought, like hypercalciuria is also only one contribution to dogs developing calcium oxalate stones. And so it's also possible that the dogs that don't have that high fractional excretion of calcium are stone formers for other reasons. And should we investigate those other causes as well? So I wanted to leave a little bit of time for discussion and then also the opinions of all the very smart people listening. And if you have any additional questions, I am happy to answer them at this time.
Great job, Rachel.
Thank you.
I think that I don't tend to use the fractional excretion just because it's more of a pain in the butt, but the urinary calcium uh, creatinine ratio, I have in the past used to help me decide whether or not to start hydrochlorothiazide maybe sooner in pets that I would be a little more concerned about forming stones quickly. So often I'll like run them and if it's high, then I'll be like, well, we're just going to pull the trigger on hydrochlorothiazide. I suspect that that is probably a bit flawed, but it does at least make me feel that I have some sort of justification to say, and you have to add another medication.
Right.
But
Right.
I
Do
haven't thought,
you
oh, go ahead.
recheck them when after you've done that to see what the levels are?
I haven't been, but I think I might start just as a kind of out of interest. Oftentimes in these cases, if they're not reforming stones, then I'm usually like, well, I don't know that I care that much. But it would be interesting to see what the numbers do.
All right, awesome. Well, thank you so much for coming. If anything pops up or if you have any questions, let me know. All right. Have a good day.
Thank you.